Welcome to our April 2023 Diagnostic Network Optimization Subcommunity of Practice Eco Session. My name is Francis Ochen from the African Society for Laboratory Medicine, and I will be your co-moderator today. The primary moderator, I will be introducing her very shortly. Our session will run for 1 hour, and we'll take a shared presentation and then get into the questions and answer session. We will take questions only through the chat room, and so please use the chat room to share your questions, comments, or any other reservations that you may have. We have language interpretation, and today we have 3 languages. So please keep off the off channel and keep to either English, French, or Portuguese, depending on the language of your choice. Today, we provide an experience on DNO analysis from Zambia. And we'll focus on integrating TB and HIV testing on GeneXpert to improve access and same-day diagnosis. Our primary moderator, like I've indicated, is going to be Jui Gautam, and Jui works with FIND as the access officer for the Global Diagnostic Network Optimization Unit, and Jui is based in India. She represents FIND as the co-lead on the DNO sub-community of practice with ASLM. And Jui holds a Master's of Public Health degree with over 10 years experience in health systems programs. Allow me now to invite Jui, who will then introduce our presenters. Jui, over to you.
Thank you, Francis. And a big thanks to the ASLM LabCoP team for organizing this eco session today. It's a pleasure to facilitate this session along with you, Francis. I welcome everyone again to the DNO subcommunity of practice eco session, and this is the 3rd session in our series. As Francis was mentioning, the DNO SubCoP, it is co-hosted by FIND and ASLM to encourage knowledge sharing and best practices on geospatial data-based analytics and how they can be used to plan and strengthen diagnostic networks. There have been 2 previous webinars conducted, and they have focused on introducing the DNO approach and some perspectives on how DNO analysis can inform, for example, the Global Fund funding requests. I will leave links to these previous recordings in the session in the chat for people who, for our participants today who might have missed those sessions, and you can review them. Coming to today's session, our colleagues from Zambia will present their experiences of conducting a DNO analysis, like Francis was mentioning. They will provide an overview of the analysis itself, how recommendations informed the ministry's activities, and also they'll be sharing some practical experiences of how DNO and similar geospatial data-based analysis can be conceptualized, they can be thought of and implemented in countries, and how they can be used to plan strategies that best support respective national goals. With that, I would now like to welcome our presenters for today. The first presenter is Powell Chunga. He's the laboratory advisor for the Ministry of Health, Zambia. Powell is a biomedical scientist and a public health specialist with over 17 years of experience in laboratory program management. He's currently working as the laboratory advisor, where he coordinates and supports pathology and laboratory services for the country. Powell is a member of the African Union Regional Biosafety and Biosecurity Technical Working Group and a member of ASLM. We are also joined today by Trevor Machila. He is the second presenter. Trevor is the Monitoring and Evaluation Manager for the Center for Infectious Disease Research in Zambia. Trevor oversees the implementation of evaluation and performance monitoring plan for the CDC health systems projects. His expertise lies in implementation of data quality assessments and data quality improvement plans, including developing relevant data quality tracking tools. I welcome you, Powell and Trevor, and thanks so much for taking the time to be with us today. Before we begin the presentation, a quick reminder, please do use the chat box for leaving your questions and thoughts, and we will address them during the Q&A session after the presentation. I now hand over to you, Powell. Please go ahead.
Thank you. Thank you so much. Thank you. Thank you. So as introduced, I make this presentation with my colleague Trevor on behalf of the Zambia Ministry of Health and in particular the laboratory fraternity in Zambia. Next slide. So very key for us is for us to understand the strategic direction for the pathology and laboratory services in the Ministry of Health Zambia. So our vision is to have a functional and sustainable laboratory services for all Zambians. That is our vision, and our mission is to provide Zambians with high quality, accurate, timely, cost-effective, and appropriate laboratory services at all levels of care and as close to the family as possible. I bring you colleagues to this mission, our mission, because it's out of this mission that we have the birth of the Diagnostic Network Optimisation in Zambia. Our mission, and I emphasize this, is to take laboratory services at all levels of care and as close to the family as possible. So it's family-centered. So how do we ensure that we take laboratory services as close to the families as possible? Next slide. So this is our current laboratory network. We have a total of 534 functional laboratories in Zambia, and these are spread across the width and breadth of Zambia, as you can see. Next slide. So in terms of our viral load and the infant diagnosis of HIV laboratory network, so we have a conventional setup where we have conventional PCR platforms in our regional centers, our provincial laboratories. And this is the diamond shape that we are seeing with color green. Then our network also involves of the hub system. So we have hub labs. So these hub labs, they hold samples and then they take the samples to the conventional PCR labs. And then we have the health facilities dotted with the small dot you are seeing here, red. And we have a total of over 3,000 plus health facilities that feed into our hub labs. And then the hub labs, eventually they feed into our conventional PCR. So with this system, you could imagine how the turnaround time is for the far-flung areas that refer their samples from the health facility level to the conventional PCR platforms. Next slide. Then in terms of our footprint for the GeneXpert platform, we have a total of 293 GeneXpert sites, whereas we have 25 conventional PCR labs. We have 293 GeneXpert. So you'll see here clearly that the spread of the GeneXpert in our country is far much better than that we have for the conventional PCR platforms. Next slide. So with the background that I've given, looking at our vision and looking at our mission of taking laboratory services as close to the family as possible, the specific disease programs, they have targets. And one of our disease-specific programs is the TB program. And their objective is to expand TB program to ensure and also assure full coverage. So one of the objectives is to increase the testing demand by 200%, from 230,000 tests that were being done on the GeneXpert in our baseline year, which is the year 2020, to over 450,000 tests. And key to note, as you shall see in the subsequent slides, is that this analysis, or the initial analysis we did for Zambia, was done in the year 2021, and we used the year 2020 as a baseline. So this was the program target, and also increase the number of sites referring samples from the 500 sites that were existing at that time to over 2,000 plus facilities. Like I showed when we looked at the footprint for our facilities, we see that we have over 3,000 plus facilities with limited number of conventional platforms and number of the GeneXpert. So meaning therefore that most of the facilities, for them to have access to the TB test, they need to refer the samples to where the platform is. Then for the HIV program also, we had program objectives or targets to improve access to early infant diagnosis of HIV, as well as priority HIV viral load testing for pregnant and breastfeeding women, and as well as for the PIDs. And also key for us was that to achieve this and improve access, then we needed to shift testing from the centralized conventional platforms to the more readily available point of care platforms. Then another objective was to increase on-site testing and also to achieve same-day results return, especially for EID. Next slide. So to answer the questions and achieve optimization and take the testing services, TB testing services, HIV testing services, EID testing services as close to the family as possible, we looked to diagnostic network optimization. And at this point, allow me to call on my co-presenter, Trevor Machera, to take through in the subsequent slides. Trevor, over to you.
Thank you, Paul. So I'll give a brief overview of what DNO is. So DNO is a geospatial analysis tool. So really it falls under the umbrella of geospatial analysis. But specifically for this approach, we analyze the current diagnostic network and recommend optimal type, number, and location of diagnostics and any associated sample referrals within the network to achieve the national health goal. So the benefit of this approach is that it can be used to maximize access to services and the overall efficiency of the system within the applied constraints. And this can help us generate insights and information that can be useful for decision-making around the test demand, testing capacity, as well as utilization, and any cost efficiencies and access to services. So in 2020-21, we conducted a DNO exercise to improve the efficiency of the lab network. And this was in line with the National Lab Strategic Plan objectives to optimize the lab network through diagnostic integration, like Paul indicated. Secondly, we wanted to maximize utilization of the existing limited resources using the DNO approach. So the exercise involved multiple stakeholders. So it was important to get input and data from different disease programs, as well as different stakeholders who were supposed to implement some of the recommendations from the DNO analysis. And this table shows the various stakeholders we worked with the Ministry of Health providing the overall oversight and coordination of the project. So a core team was set up, and these are the key staff that were involved in the DNO exercise. So with lab advisors from both the Ministry of Health as well as FIND and CIDERS. So we also had data analysts from CIDERS, so they supported data preparation and analysis of the results. And we also had technical support from FIND and HERO during the exercise. And they helped us build in-country capacity to ensure that the DNO exercise is sustainable in the long run. So the overall objective was to optimize the diagnostic network to ensure that the priority HIV viral load testing for pregnant and breastfeeding women, pediatrics, and early infant diagnosis could be tested on site or shifted from conventional platforms to GeneXpert platforms, whilst ensuring that TB testing was not negatively impacted. And the key question we're trying to answer was how can we optimize the network to improve access to early infant diagnosis, as well as viral load testing for pregnant and breastfeeding women, as well as children under the age of 15 years. We also wanted to assess whether there is enough capacity for testing after closing the obsolete CAP-CTM machines, and also whether there is enough capacity to accommodate COVID as well as HPV testing. So to answer the questions, we used OptiDX, DNO software. So we first established the baseline network using 2020 testing demand, the referral linkages testing sites, also incorporated all the platforms within the network and the costs associated to the HIV and TB programs. We then incorporated the future testing demand based on the program expansion targets. And to improve access, we integrated priority HIV viral load testing, including early infant diagnosis on GeneXpert platforms, which were previously used for TB testing, and then closed all CAP-CTMs, which were obsolete that year. We then calculated the annual device cost, variable costs, as well as test costs, and the sample transport cost for each scenario. Lastly, we assessed how additional capacity could impact the results. Okay, so from the analysis, these were the key takeaway messages. So we can expand the TB program and improve the HIV testing access within the current capacity. However, a number of sites were operating over capacity, and these were largely the smaller labs operating the one shift for 4G and using the 4G GeneXpert platforms. Secondly, closing all the CAP-CTMs and shifting EID and priority viral load testing on GeneXpert resulted in large access benefits, in that the average transportation distance reduced by 10-fold. The third message was that placement of GeneXpert 16s at higher volume laboratories resulted in a cost saving of about 4%. And this really came from the reduced reagent rental price, as we could meet the average, as we could meet the minimum test per device requirement for the rental agreement. And also recommended placing GeneXpert 16s at high demand sites and extending shifts for GeneXpert 4 devices. So can we expand the TB program and improve access to HIV access with the current capacity? So the answer to this question was yes. So as you can see, the yellow slice shows the number of priority viral load tests as well as AD tests by device. So most of the tests in the historical baseline were tested on the CAP-CTM. And we have so the ones in blue are tests that are conducted on the COBAS, and the green shows the tests that are conducted on the Hologic. And in terms of the proportion of tests conducted on the GeneXpert, so like indicated by Paul, the GeneXperts were primarily used for TB testing, and very few priority HIV tests were conducted on the GeneXpert. So there was enough capacity to shift priority HIV testing to GeneXpert devices. So with the future demand scenario, we can see the larger proportion of tests on the of viral load and EID tests were EID and viral load, with most of the tests conducted on the GeneXpert, as shown with the brown slice there, and a few tests were conducted on the Hologic. And in terms of proportion of tests conducted on the GeneXpert, we can see an increase in proportion of tests conducted compared to the baseline. and the average utilization increased to 48%. So it's also possible to expand the TB and the TB and the improve TB HIV access. As we can see, the average sample distance decreased by tenfold, except for the adult VL, which were still being tested on conventional platforms. And as we can see, the TB program was not negatively affected. So the number of tests performed increased for TB and HIV, despite the large program expansion goals. Yes, so whilst the average utilization is below 50%, we saw that the number of sites were operating over capacity. We're shifting, decentralizing both TB and priority HIV program, and closing the CAP CTMs placed pressure on the smaller labs. And 9 out of 10 of these labs were operating, the majority of tests were TB with over 75%, and over 84 sites were operating over capacity. And largely these were GeneXpert 4 devices operating one shift. So possible solutions were to add more devices to the network, or relocate underutilized devices, or extend shift hours for sites that are operating one shift. Okay, so in terms of recommendations, so placing GeneXpert 16s at high demand sites ensures that we meet the minimum test requirements, and this resulted in a lower reagent rental price. Secondly, we recommended relocating devices that are underutilized to sites we expected high utilization, or sites that are overwhelmed when the maximum allowable distance constraints were enforced. Thirdly, we recommended extending shifts for one GeneXpert 4 devices where possible, to accommodate the increase in demand and reduce utilization from over 40%. So the outputs and recommendations were presented to the TWGs for validation, and I'll hand over to Paul to discuss how we implemented the recommendation. Over to you, Paul.
Thank you so much, Trevor. Thank you. Next slide, Trevor. Thank you. Next slide. So with the recommendations that we were made from the analysis that we did, we moved as Ministry of Health, working with our stakeholders, the partners, to implement all the recommendations. And the first one, as you can see on the left here, we adopted roll-out implementation of priority viral load testing for pregnant and breastfeeding women, and for the children under the age of 15 on the GeneXpert platform. And the Ministry of Health sent out a central level memo to the facilities to communicate that implementation. As we can see, the circles with the heart inside, this is our diagnostic sites that were recommended to implement point of care testing or disease integration, as it were integrating HIV in the already existing TB testing. And then the black dots, these are the spoke sites. So we are implementing a hub and a spoke model. And then the flat line, they're representing how the sample referral flow works. So we have a network in place that ensures that samples move from the spoke sites into the diagnostic sites for point of care testing. And also here we see, in terms of in the future, in the futuristic state, we see that it will be running more of referral sites on the point of care platforms than the on-site sites. So the color, the bar charts here, the color is showing black. It is showing the number of tests that will be run on site, and then the color brown or red, it is representing the number of referral facilities or the referral tests that will be run. But key to note here is that with the multi-disease optimization in the future, we'll now be able to capture more of the tests that are currently not moving from the SPOC sites into the hub sites, thanks to the optimization. Next slide. In terms of the implementation process, this is the process that we followed to implement our recommendations. We first of all did site readiness assessments. So we did create a checklist. We created a checklist that was checking on HR availability, that was checking on the capacity, existing capacity, like Trevor has alluded to, and also availability of laboratory function management system, availability of power backup system, among others. And from that assessment, which was done, 83 facilities out of the 123 which were recommended were assessed and were recommended for activation. And then after the site readiness assessment, those that met the criteria, then site trainings were conducted. So trainings were done, and then the materials were distributed in terms of the SOPs, which were developed, the monthly reporting tools, as well as the cartridges for us to commence the testing. And also after that, site activation now was done. And at the time of this analysis, December 2022, when we're putting the position together, 82 sites were successfully activated for both priority viral load testing as well as AID as well. And we've made a policy now that in terms of rollout of lab information system, we are prioritizing the sites that have been activated for TB as well as viral load and AID testing. And to date, we have a total of 73 sites that have where we have managed to successfully install lists. And then, so when you look at this cascade, we are operationalizing, testing is happening, and what is continuing now is just performance monitoring and the evaluation, as well as technical supportive supervision to the facilities. Next slide. So routine implementation monitoring is a continuous process, like I've already indicated. We've managed to activate or install this on this point of care platforms. And to note, and this is a best practice for us, in that we have established a monthly national multi-disease update meeting. This meeting is held monthly to monitor progress towards the integration. So all the partners, the Ministry of Health and all the partners, we meet monthly and we monitor the progress, and all the challenges are addressed there. Best practices are addressed there, and they are shared there during our monthly meetings. Next slide. So in terms of impact of the evaluation, we see here that while where we are coming from, the GeneXpert were exclusively used for TB, but in the year 2022, we see that up to 27% of all the tests were integrated, were coming from HIV. 23%, we have 21% coming from EID, and 2% coming from viral load, and then TB 77%. So this is an achievement for us. We see here that out of all the tests which were done, TB contributed 114,000 tests plus, then EID contributed 32,000 tests plus, and viral load contributed less than 3,000 tests. Key to note here is that our turnaround time was drastically improved. So we have a lab turnaround time of 1 day, and then patient turnaround time of 2 days, especially for the SPOC sites. I did speak to improved courier system that feeds into the hub sites. Next slide. So in terms of our annual performance, here we review the year 2022, January to December. You see here that the numbers in terms of the tests that were being done for EID and viral load, they were steadily increasing. And for this year, 2023, we see the numbers even increasing more, thanks to the demand creation activities that have been triggered. Also key to note, and why we have less numbers for viral load, project viral load, is because project viral load commenced around around March, April 2022, whereas from January, even in the year 2021, we were running EID. So EID started first, and then viral load point of care came in later. Next slide. So this is just showing the proportion of tests done on the point of care versus conventional platform for EID. So in the year 2021, we see that 91% of all the EID tests were being done on the conventional platform and only 9% on point of care. But in the year 2022, we see that 75% of the tests were done on conventional platform and 25% on EID. And this improved our overall turnaround time. Next slide. So in terms of sustainability of DNO recommendations, how sustainable are the recommendations? Number one is that we have managed to improve access to testing, in that increased testing capacity. Multiple tests can be conducted without additional equipment and HR requirement. Like we have said, we were using the GeneXpert primarily for TB. We did not have to procure additional point of care platforms for us to run EID and to run a viral load, but we use the same platforms, giving us access to other tests as well. Also, the other factor we see is the cost effectiveness. Like Trevor did allude to in the presentation, there are cost savings that have accrued through the reagent rental arrangements, and also reduced transportation costs. We don't have to send the samples now to the conventional PCR labs like I did show, which are dotted in far distant areas, but we've created hub models and just reducing the cost for transportation. The cost for trainings also, they have reduced. Previously, we would hold trainings for TB alone, trainings for HIV alone, but now it's integrated. So within the same trainings, within the same limited funds available, you would cover trainings for TB and for HIV as well. Then also infrastructural costs, in that setting up, just using the GeneXpert platform, you don't have to set up multiple infrastructure for you to be able to do the viral load or EID tests. So all these are sustainability issues that we are seeing, and this is sustainable even in the future. Supply chain management also, it's coordinated and integrated as well. Next slide. So challenges are there, and most of the challenges we are facing around implementation of DNO is purely or data. They are data related, and this is true for CD4, for chemistry, hematology, because we are in the process of right now running analysis for CD4, chemistry, hematology, and the data is available, expected to be available by June. But the challenge we have is that data is not harmonized, it's not standardized for CD4 chemistry and the hematology, and hence it takes time for colleagues that triangulate and collect data. That is the biggest challenge that we currently have. Next slide. So ongoing works, I've partially alluded to this. Of course, we continue integrating tuberculosis and HIV on the GeneXpert platform, also optimizing for CD4, HPV, hematology, chemistry testing as well. So this is in progress. We hope that the analysis will be available by June. Also, evaluation of the impact of the DNO in our country. So we are developing a protocol where we want to get ethical approval for this, so that we clearly analyze the impact of DNO. A good draft is available, and soon will be doing the impact evaluation. Next slide. So this work we are presenting here has been published, as you can see, colleagues, and we invite you to visit this site and be able to acquaint yourselves with the details of the analysis that we did. Next slide. So thank you so much. We most sincerely thank our colleagues and the partners that we worked with. I cannot mention them, but we can see them on the slide. Thank you so much. Our submission.
Thank you, Pavel and Trevor. That was quite an intensive and detailed presentation. It was good to see not just the analysis, but also good to hear a little bit about how the ministry went about conducting an analysis of this nature, and how the findings have actually informed some of the implementation already. I see the comments box that is flooded with many questions, and I'm sure we are all eager to hear our speakers respond to those. So I'll start maybe grouping some of these questions together, and I'll Pavel and Trevor, please feel free to take them as either of you you would feel comfortable addressing those questions. So to start with, there are a few questions around the availability of platforms and equipments. So there was a question if, apart from GeneXpert, there are any other point of care platforms in the country. And our participants, one of them would also want to know about the breakdown of platforms that are used in the 25 conventional PCR labs. So are there any other point of care platforms, and which are the conventional PCR labs? If you could provide a quick breakdown of the platforms. I'll stop for your responses.
Thank you so much. We are from Zambia. Other colleagues also from the Zambia team, they are welcome to respond some of the questions, but I'll take this one on. So in terms of other point of care platforms, yes, we do have other point of care platforms, but the key one that we use leading and widespread is the GeneXpert, and it's a true remote disease testing platform, and it's in over 293 facilities, like I did allude to. The footprint for other platforms, it's available, but it does not match that number. In terms of our conventional platforms, so we have a mix of Roche platforms and Ologic platforms as well. Ologic, Panther, and the Roche platform. That is what is in our conventional laboratories. Thank you.
Thank you, Pavel. The next set of questions are around, I see a few around how the priority groups have been defined. So I think it would be good to understand the rationale that the ministry had while defining the use of point of care for children and pregnant women and breastfeeding women. And there are questions around how can other priority populations be also considered. For example, patients, there is a question on patients with previous high viral loads as priority populations. Also, what about other diseases such as HPV within the context of multi-diseases testing? So I'll hand over to you, I think, Pavel, for answering that, or anybody else from the Zambia team. Please go ahead.
Thank you so much. I'll start, and then colleagues can also amplify from Zambia before we can hand over to you. So in terms of what informed us choosing the priority diseases, like we did state in the third slide, I think, the different disease programs had priorities which they gave to us as lab. A key to note is that lab performs a support function to the clinical program area. So the TB program had targets to improve coverage from about 230,000 tests to close to 500,000 tests. and also the HIV program, they had their targets to provide for priority viral load, and the definition of priority viral load is for pregnant and breastfeeding women and for the children. So these two categories were prioritized by the programs, and we moved to support and implement that like we have shown. In terms of increasing the scope beyond HIV to cover HPV and other diseases as well, those works are in progress, and are the ones I alluded to, that the findings are expected to be available by June. I don't know if there are any additions from the Zambian team. Okay, I see none. Over to you. Thank you.
Thanks, Paul. I think moving to the set of questions around impact of how these improvements have shown on-ground impact, and how have they improved the indicators that the ministry was interested in. So the specific questions are: has this arrangement resulted in a reduction of cost of service and maintenance of the GeneXpert equipment? Did it translate to same-day testing and provision of results? So whether these, these improvements have already been observed. And similarly, there is also, maybe I can just add this point and then hand over back to the Zambia team for the responses. There are also questions around how did the use of GeneXpert for viral load and EID impact? Did that have an impact on TB testing, which I know was something that was considered when this analysis was being done. So it would be interesting to hear your response to that. Finally, there is a question also around considering that samples are still, routine viral load samples are still being sent to conventional labs. How cost effective is this TB HIV integration on the GeneXpert devices? So I hope I did not overload you with the questions. I can repeat them if there were many, but they were all related to impact. So I thought it would be good to bundle them. Please go ahead.
Thank you. Thank you so much for that. So in terms of improving on our performance indicators, yes, the answer is yes. The coverage, viral load coverage has improved in those population groups where we are implementing point of care testing. That is a direct. And also in terms of cost, yes, the cost has really reduced, especially if you look at the courier costs. Those have significantly been reduced. I'd want to call on my colleague Judith to amplify further on the response that I've given, and also any other responses that I may have given, I may have left out. Judy, are you available to amplify? It appears Judy is not available, but pretty much the responses that I've given, that is how the statuses or indicators have been impacted upon. The cost has been impacted upon, like I have indicated, and also there is improved engagement with the vendor. There is improved engagement with the vendor, and also the KPIs that we've given to the vendor, they have also improved, because there is increased stakeholder interest in ensuring that all these diseases they are addressed, and that the GeneXperts the uptime is improved. So we have seen improvement in terms of service provision by the vendor, and by this because of the multi-disease testing on the GeneXpert platform in our main laboratory technical working group, on a quarterly basis, we're having the vendor coming and present on their KPIs. Like I've said, because of stakeholder interest, so everyone wants to ensure that the GeneXperts are running optimally. So those are some of the positives or the direct impact that we have seen from this exercise. Thank you.
Thank you, Pavel. Next, I think I'm going to take a couple of questions that I see around the software, the OptiDX software, and maybe Trevor, these might be questions that you would want to respond to. So the questions are, if you can elaborate more on the software, what did you use it for? And what were some of the challenges? And while you respond to that, I know, Trevor, that you will be talking about data challenges as one of the issues. So I'll also maybe taking two questions specifically around data. So there's a question around how did you identify the data for the high priority VL? Did the country data have it in detail, or did you have to work with stakeholders to, develop percentage assumptions for these high priority populations? So that's one around the data for high priority VL. There's also second one around what are the characteristics of a high demand facility. So was there a minimum size of the patient catchment area? And is the high demand for both VL and TB testing or just viral load testing? So maybe I can let you respond to these questions, Trevor. Please go ahead.
Thank you, Joy. So for OptiDX, it's a DNO software which was developed by Find. So we used the software to create a digital model of how the current diagnostic network is. So it actually includes the location as well as the capacity of all the diagnostic services. So we also use the software to run customized scenarios and compared scenarios, factoring the different constraints that we applied to the models. So it's simply a DNO software that was used to create the digital model and run the optimized scenarios. With regard to the data challenges, I think Paul highlighted some of the challenges. Some of the data was not in the format that was required for DNO. So we needed to ensure that we organize the data in a format that's needed for DNO. And with regard to the high volume sites, so most of these sites have testing over 1,000 samples per day. So those were categorized as the high volume site. So unless I missed any other question.
Thanks, Trevor. I think there was one around if there were any other challenges that you would want to talk about when using the software. And yeah, I think that was it.
Okay, so some functionality were not present at the time of the DNO exercise. So we're mostly in constant engagement with Find as well as LlamaSoft, the developers of this software, to ensure that we included some of the functionalities that were missing for us to answer the questions that we presented. So some of those functionalities were missing, so we had to provide feedback to the developers, and they resolved some of those issues.
Okay, thanks, Trevor. All right, I think I will now move on to a couple of questions that I see around the feasibility of implementing some of these recommendations, given the issues that are often seen around availability and costs of consumables around required for GeneXperts. So there are questions around what was your experience in case of availability and costs of cartridges, and what if any strategies were used to reduce the module breakdown. And my assumption, my reading here is that the participants here, whoever posted the question, would want to understand if we are shifting, if we are integrating HIV testing along with TB testing on GeneXperts, that can be expected to further add to the to the challenges that we see. So was any of that taken into consideration, and how, while implementing these recommendations? And there is also a similar question around sustainability of these GeneXpert machines in the longer run, beyond the support provided by stakeholders. So maybe I'm not sure who would want to take that. Paul, would you perhaps want to start?
Okay, thank you so much. Thank you. So I'll start with the maintenance and then end up in terms of cost. So in terms of maintenance, like I did allude to, because of multi-stakeholder interest in this, integrating all these diseases, the local vendor, the one who maintains the equipment, they are now improved in terms of servicing and the frequency of visiting the sites. Their KPIs, performance, if I remember very, very well, we were around 55%, but in our last meeting, they're around 88% improvement. So that is significant improvement. And the maintenance, we don't have a maintenance challenge now. All the models that are failing, they're being replaced on time. So we don't have major challenges with regards to maintenance of the GeneXperts as well. And also we have built in help desk has been put in place. So facilities are able to quickly log in what their challenges are, and using the help desk, they're getting the assistance. So this has happened thanks to the integration that we have achieved, and that has increased the voice of the stakeholders that are speaking about ensuring machine uptime. So we have seen that, and like I did allude to, the monitoring and the coordination mechanism that is in place is that the vendor appears before the laboratory technical working group, and they present their KPIs, and all the stakeholders contribute to improvement. So that is what the question on the maintenance. In terms of cost, yes, the cost for the cartridges, the cost per test in terms of, you look at the procurement of the cartridge and providing the test for the conventional, the cartridges, they cost more. But if you factor in the cost for the courier system, then that cost is offset. Because if you look at the whole continuum of care, ensuring that the result is returned on time, the cost, your savings from the courier, and also the cost savings from the reagent rental arrangement that have been put in place now. So the eventualistic cost per test is offset. So we see that there is value in investing in if you look at the bigger picture, like I've alluded to. I don't know if I've answered all the questions, or if there are additions from the Zambian team.
Great, thanks, Paul. I think that responds to the queries that were posed. I am looking at the time. We have just under 10 minutes, and there are still questions that are coming in. So maybe what I can do is also, while we are on the topic of sustainability of these improvements, there are two questions around waste management and around quality monitoring. So how is the ministry approaching the issue of increased, because there will be increased GeneXpert utilization, and how is the need for more waste management for cartridges and waste liquids? Has that been taken into account, and what are the plans around that? And secondly, what is the plan for quality monitoring of EID and BL testing on the GeneXpert devices? Over to you.
Thank you. Thank you. I'll take the question on West, and then I don't know if my colleague Mutinta Yombe, she's on the call, the colleagues from the quality office, they'll take up the quality question. So in terms of West management, very aware that the cartridges, they contain guanidine cyanate. So what we do is that we have gone in an arrangement, and it's one of the performance indicator that we've given to the vendor, in that they distribute the waste containers to all the sites that are activated. And then number two is that we have scheduled the pickup of they use the cartridges for disposal at the safer and the centralized site. So that's how we are currently managing the waste disposal component. So we don't dispose of the cartridges on site, but they are collected on a scheduled pickup, and they are disposed of in a safer way at a central facility which meets the required standards. I don't know, colleagues Mutinta, Patricia, to respond to the quality question. Peers, I can't see colleagues, but I would respond to it. So all the testing sites have been enrolled in the quasi external quality assurance program scheme. So all of them, they are enrolled in that. At the beginning of it, we enrolled them in the external quality assurance scheme. We were running what we're calling a 10th sample. That's what we were doing at the start of it. So every 10th sample would be kept and taken to the conventional platform. But now we've moved on, and all the laboratories have been enrolled in an EQS scheme. So that's how we are managing the quality aspect. Thank you. Mr. Nsama, also from Zambia, I see his hand is up. Mr. Nsama, you can proceed to make your submission.
Thank you. Thank you very much. I have internet issues where I am here. I don't know if the EQA program was answered. I just want to, in case anything was added by our colleagues, want to put it that all our GeneXpert platforms have been enrolled in the quasi EQA program. So in terms of quality, we're using this EQA program to monitor quality performance of all the instruments that are enrolled in this DNO program. And then for waste management, we are actually also in the process of transitioning to non-GTC cartridges. This activity, we're working with the vendor and Cepheid to see that we do an evaluation and then see how we can implement the non-GTC cartridges to alleviate the waste management program or challenges, which we are currently taking all cartridges, GTC cartridges, to a central site where they are being managed. Thank you very much for that. I hope I was unmuted by the host.
Yes, we are. Your submission very clear, very clear. Thank you, Mr. Nsama. Thank you.
Thank you. Thank you, Nsama. Thank you, Powell. I see we are at almost towards the end of the session today, and I recognize there are a lot of questions that we have not yet been able to get to, but just in the interest of time, what we can probably do is take a few final closing statements, maybe from Powell and Trevor, if you would want to share any closing remarks. And we will try and answer the questions that are here in the chat over email post the session. And after your comments, I will hand back to Francis for wrapping up the session today. Thank you.
Thank you so much. No really comments from me or remarks, but just to thank ASLM, to thank FIND, and to thank all the participants that have joined in. And also we are very thankful and delighted for this opportunity for us to showcase our works here in Zambia. So thank you very much to everyone. Thank you.
And nothing to add from my end. Thank you for the opportunity to share the Zambia experience.
Thank you. Thank you very much, Joey, for a very well-moderated session, but also our facilitators, the presenters who've done a great job today. We've got to know that it is possible actually to improve access within and across disease programs when a deliberate and structured approach is implemented with fidelity. It is also true that you can get collateral benefits. You can call them knock-on benefits. When you get programs, partners, and stakeholders beginning to talk more with each other, given the diagnostic network optimization initiatives. We've come to almost the top of the hour. Thank you so much for joining. I hope you've learned a thing or two that can improve your structuring of your DNO should you choose to go that way or otherwise. Like Joey indicated, the questions that are pending, we will deal with them and share those questions and the presentations as well as the recording of this session through the emails that you shared. We had also put up the certificate code for you to download your certificates from the ASLM Academy. And so from us, this side, we'll bring it to an end and wish you a very good rest of the day or evening or afternoon, wherever you're joining us from. Until we meet again in our next session, bye-bye, and do have the best of your rest of the day. Thank you.